We have the pleasure using some technology of welcoming Dr. Zhiyong Peng, who is Chair and Professor of Critical Care Medicine at Zhongin Hospital and Vice Director of the Center for Clinical Trials at Wuhan University, who is going to present a videotaped a version of a talk on 138 patients who've been infected with coronavirus COVID-19. And if the technology allows, perhaps he'll be able to answer some questions.
Hello, everyone. It's my great honor to be here to share my work with you. My topic today is 2019 novel coronavirus pneumonia in Wuhan, 138 case analysis from a single center. I'm Dr. Peng, intensivist from Wuhan University. The novel coronavirus pneumonia, which is called NCP, is widespreading, highly contagious, and become public health emergency of international concern. This figure demonstrates how this problem spread so fast within 20 days from one area to other areas. This also demonstrated the number on February 6th of the patients. The confirmed case patients is around 28,000. The suspected cases is around 24,000. So I try to summarize the clinical features of the NCP patients from my current database and try to describe the disease process and the epidemiology features and try to compare and analyze the differences of the patients in ICU and outside ICU. This is the retrospective cohort from a single center. All the patients enrolled from January 1st to January 28th. All the patients were confirmed using both of the criteria, including typical chest CT scan and the positive real-time RT-PCR assay. We collected the following data, including the demographic data, the underlying comorbidities, symptoms, signs, NAP, chest CT scan, treatments, including medications, mechanical ventilation modes, and other organ supports. Results. This is the basic features of the NCP, including the age, gender, comorbidities. It was likely to affect old persons with comorbidities, and the patients in the ICU were relatively older and much more comorbidities than the patients outside ICU. This table demonstrated the symptoms and signs of NCP. The most common symptoms, including fever, fatigue, dry cough. Around 10% of the patients presented initially with diarrhea and subsequently developed fever and dyspnea. Dyspnea, abdominal pain, very frequently occurred in ICU patients. This is the clinical process of NCP. The time from the first symptom to dyspnea was 5 days, 7 days to hospital admission, 8 days to ARDS. The most common NAP changes including the lymphopenia, prolonged prothrombin time, elevated lactate dehydrogenase, and the patients in the ICU were relatively lower lymphocyte counts and relatively higher lactate dehydrogenase compared to the patients outside the ICU. This is the dynamic changes of the lab test in some patients, including survivors and non-survivors. The survivors labeled with blue color demonstrated lower white count, lower neutrophil count, and higher lymphocyte count, lower D-dimer, lower urea, and lower creatinine. This is very typical chest scan in one patient. A is the time in day 1. You can see the bilateral infiltration in this patient. B is the after 2 weeks treatment, the infiltration, the opacity become better compared to the A. This is the general features of the ICU patients. They have higher ABA2 score, higher SOFA score, and lower PFO ratio, around 136, very, very low. These patients in ICU always develop the organ injury. The most common organ injury and the complications including ARDS, cardiac surgery, arrhythmia, and cardiac injury, arrhythmia, and septic shock. Regarding ventilation support, only around 10% of the patients survived from the high flow oxygen therapy, and 40% of the patients received non-invasive ventilation. About 50% of the patients needed invasive mechanical ventilation. 10% of them switched to ECMO. About the prognosis, on February 8, 40% of the patients still in hospital, 50% discharged, and 5.8% died. The hospital stayed around 10 days in survivors. Here, we also presented the updated information today on February 10. We took around 50 patients already in my ICU. Most of the patients right now much more severe because some transferred from other hospitals, and 60% of the patients needed invasive mechanical ventilation. 11 of them switched to ECMO. 4 went off ECMO already. Another issue about the transmission, you can see the figure, almost 40% of the patients transmitted in the hospital, including the medical care professionals and the hospitalized patients. About 70% of the infected healthcare workers from general ward, around 20% from ER, 5% from ICU. About the hospitalized patients, 40% infected in the surgery department, 30% from internal medicine, 30% from oncology. In conclusion, the transmission of the NCP was frequent, especially in the hospital. The atypical patients were probably the main source of the transmission. Critically ill patients tended to be older with comorbidities, specific symptoms, and lab abnormalities. The most common complication was ARDS, arrhythmia, and septic shock. Nearly half of the critically ill patients needed invasive ventilation. Thank you for your attention. Thank you for inviting me. Thank you for your support to my city, to my country, to my patients.
So I believe if the connection works, we may be able to have a question or two for Dr. Peng. After all the speakers, okay, in a few moments. So our next speaker, Dr. Ryan Maves, is going to talk about the 2019, or actually I guess the 2020 novel coronavirus, what we know so far.
Good afternoon, everyone, and I want to obviously thank Dr. Savransky and Dr. Pasquale and Dr. Howell and the remainder of the program committee and all of you for the opportunity to speak to you today. So I'm Ryan Maves. I'm an infectious disease and critical care physician in San Diego. I do work for the federal government. Just to point out that the opinions in this presentation are mine and do not reflect the policy of the U.S. government. I have no financial conflicts of interest. I will talk about some off-label and investigational drugs. So coronaviruses are a large family of zoonotic viruses spread to humans through some, usually mammalian intermediate, very often bats. So human coronaviruses, there are 7, including the new novel one, which probably comes at us from a bat, most likely. It's part of a group called beta coronaviruses, which also includes the other 6 human infections, the 4 usual human coronaviruses, which cause a relatively mild respiratory infection in most patients, SARS, MERS, and now this novel one. Very recently, the International Commission on Taxonomy in Viruses has decided to name this SARS coronavirus 2, due to a high degree of homology with the previous SARS coronavirus from 2003, 2004. There is a little bit of controversy about that, but right now NIAID is using that name on its website. So this virus is 79.5% homologous with SARS-CoV, with the original SARS, and is 96% identical at the whole genome level to a previously identified bat coronavirus. Its target in the human respiratory tract appears to be angiotensin converting enzyme 2, which is similar to the older SARS-CoV, and is presumably, although not yet 100% certain, to be the root of infection. It's a pretty typical looking coronavirus, 4 structural proteins and a single strand positive RNA genome there in the middle. All right, so I updated this morning, and I have to say this is interesting for a talk in that it is almost certainly out of date by the time I give it. But there are approximately 72,000 cases reported to WHO. This is the Johns Hopkins CSSE website that tracks this on an ongoing basis. So about 72,000 cases, 1,775 deaths reported so far. Overwhelmingly, these are in Hubei province in China. Handful of cases in the United States, 15, possibly going up, and a variety of cases in the remainder of Asia, Europe, elsewhere in North America. So far, not quite 12,000 people are reported as recovered, so a number of these people remain hospitalized or remain ill. So early on, cases were linked to the wholesale seafood market in Wuhan. There were some attempts to assess whether or not this was due to animal exposure in the market, but it turns out there were a number of cases that didn't have an epidemiologic link to the market that occurred very early on. It is possible that the market, which is a crowded aggregate setting, could have been an amplification for the outbreak, where someone who was infected entered the market and then transmitted it within the market, leading to the outbreak within the city. That remains unproven, but if you look at one of the early Lancet series here, blue are the non-market associated cases, red are market associated cases. And you see that these blue cases occur pretty early. So again, the market may not be the source, but rather a source of amplification. All right, so transition dynamics, we're still learning how this virus is transmitted in nature. So in general, coronaviruses and other respiratory viruses have about a 2-meter range. That is, for coughing on someone, the zone of maximum danger is about 2 meters. It's like when you're on an airplane, how many rows do you have to be away from someone with influenza before you're at lower risk? Other coronaviruses persist in the environment in sort of room temperature, low humidity conditions for up to 4 days. What the implications of that are going to be for this virus and for infection prevention with hospitals is still being determined. Another topic you probably have seen in the news, this idea of the R-naught, that is the number of secondary cases that arise from a primary infection. So the estimated R-naught for this novel coronavirus is somewhere between 1.5 to 3. That's still being sorted out. And that can change over time as changes in a population in terms of immunity and exposure evolve. So for example, H1N1 influenza had an R-naught of about 1.5. Measles in an immunologically naive population is an R-naught of 12 to 18. So very, very contagious. The original SARS from 2003-2004 had an R-naught initially about 3.5, but as environmental and policy controls were put into place, that declined very rapidly down to 0.7. And that's part of why that epidemic did not propagate further. All right, so there are a couple practical things for critical care professionals to know about. One is, how do we identify what we call a person under investigation or person of interest who is at risk for having this infection, having COVID-19, and determining whether they need further workup. So there's kind of a sliding scale of severity and epidemiologic risk that will determine the risk. So the highest risk category is going to be someone who has been exposed to a confirmed coronavirus case or has had a laboratory exposure to the virus itself. Those people can have fever or signs and symptoms of a lower respiratory tract infection. That would then be sufficient to put them into being a person of interest who would require further evaluation for disease. And someone who has traveled to Hubei province in China within the last 14 days, the case definition is fever and signs and symptoms of a lower respiratory tract illness. And then in someone who's been simply to mainland China within the last 14 days, it's fevers, signs, symptoms of a lower respiratory tract illness, and illness severity requiring hospitalization. So the scrutiny goes up, the less firm the epidemiologic risk is. And this is continuously updated at CDC, and this may potentially evolve over time as our understanding of the epidemiologic risk factors and as the nature of this outbreak evolve. So CDC also has a flow sheet, and Dr. Evans will go over this in greater detail, but I think it's important enough to take more than one look at. And this is something practical for application in the hospital, and this is again available on the CDC website. So a patient who has had travel to China or close contact with someone with a known case of COVID and has fever or signs of a lower respiratory tract infection, that's a person who we should at least consider this as a possibility, with further assessment of the risks and the institution of some initial basic infection control measures that, again, my colleague will discuss in greater detail. All right, so this is Dr. Peng's paper, and again, with nothing but gratitude for him for the work that he's doing, taking care of hundreds upon hundreds of patients in his home city. But just to reiterate the key points of his paper, 26% of his admissions required placement in the intensive care unit, and there was a median time of 10 days between onset of symptoms and development of severe disease requiring ICU admission, with 60% of them having ARDS, half of them requiring mechanical ventilation, and a large and, well, a substantial amount of patients requiring ECMO and or vasopressors. So their overall mortality is 4.3%, but a lot of their patients remained admitted at the time of that publication. And markers of severe disease and risk of death included lymphopenia and neutropenia, that the non-survivors had sustained neutropenia and lymphopenia, whereas survivors tended to have recovery of their cell lines earlier on. But that 10-day period is important, right? Because I think that may inform what we do for treatment. If this is a late, for example, immunologic complication, that could affect timing of antiviral therapy, much like neuraminidase inhibitors in influenza, where their efficacy is greatest the earlier you start them in relationship to their symptoms. So diagnostics. So if you look at the report on the multiplex PCR in your hospital, there will be a line that will say coronavirus. That test does not detect this virus, right? That detects the 4 conventional human coronaviruses. It doesn't detect SARS, it doesn't detect MERS, and it doesn't detect this. So all diagnostics have to be done in coordination with your local public health authorities. In the United States, that would be your county public health department or analogous organizations in your home of origin. Testing until very recently was done entirely at CDC. That led to some time delays because of bottlenecks. That is now improving as other laboratories around the country have access to the primers and probes and can perform this closer. But again, all of that does need to be coordinated with county public health. So when we identify those PUIs that we described before, the next step is to call, after taking care of the patient, calling the county and finding out, is this person suitable for screening? Should I be sending assays off to one of these reference laboratories? All right, so clinical care. There's not a lot to say about clinical care yet, and certainly nothing that I could add to Dr. Peng's presentation. Care is principally supportive, and staff safety, when you saw those high numbers of healthcare workers infected, staff safety is always going to be at the top of the list, right next to care of the patient and safety of the patient. So potential interventions that are under at least consideration. Glucocorticoids are used in a large proportion of the cases in China and in Japan. They are not presently recommended for SARS or MERS. Whether they will have a role in this disease, I think, remains to be proven. Certainly, if someone has another indication for glucocorticoids like vasopressor-resistant shock, that would be another story. Bacterial co-infection is reported in about 10% of patients, and there may be a role for empiric antibacterial drugs. Investigational therapies, the one that's gotten the most press is remdesivir, which is a viral RNA polymerase inhibitor under evaluation by Gilead. This is available as an as an emergency IND, but use of this drug should generally be done in coordination with a registry, such as the MEURI framework for the use of investigational emergency agents, so that we're getting good data and can have an idea of what is the actual use of these drugs. There are a number of randomized trials that are in development and moving towards approval very rapidly, and if you look in clinicaltrials.gov, there are 50 RCTs right now for novel coronavirus and a equivalently large number on the WHO website. There is some interest in Asia looking at lopinavir-ritonavir, which is an older antiretroviral drug. Whether that has any benefit remains to be proven. Another thing just to make a push for is the idea of standardized data collection. One of the challenges in other epidemics was difficulty with comparing different case series. We'd have cohorts out of multiple different institutions around the world, and comparing those cohorts in an organized manner was difficult. So within the Society of Critical Care Medicine, the Resilience Intelligence Network, under the leadership of Dr. Perrin Cobb and a number of people in this room, is looking to develop networks to permit the standardized data collection in public health emergencies. Internationally and under WHO auspices, there's an organization called ISARIC, the International Severe Acute Respiratory Infection Consortium, which has a standardized protocol with standardized case report forms that you can download off the internet and are available to use only requiring attribution. And that sort of thing will help us make our data easily interpretable between each other. And then there's other comparable protocols in development. So just for a little bit of perspective, obviously this is a public health emergency. Right now, as of this morning, about 72,000 cases of COVID in the world, about a little more than 1,700 deaths. Each one of those deaths a tragedy. In the United States, in a typical influenza season, there are 30 million cases of influenza, and there are 30,000 deaths. So while this mortality is troublesome, we should remember that this is flu season, remember to look out for influenza, remember to take standard precautions for other comparable respiratory diseases, right? So in summary, this is a dynamic and rapidly evolving outbreak, and the direction this is going to take in terms of our hospitals and in terms of global public health remains to be determined. Current case fatality rate, 2 to 3%. The impact of mild or subclinical disease is unknown. There are going to be a number of undiagnosed cases, and how that'll affect the case fatality rate is unknown. Care is primarily supportive. There are some investigational therapies that will be under study. Priorities for us in our hospitals: early detection, infection prevention, staff safety, and obviously taking care of sick people. Thank you very much for the opportunity, and we'll be available for questions afterwards. Thank you very much.
So again, at the end of this second half of the session, there'll be time for questions, I hope, with Dr. Peng available. Our next speaker is Dr. Laura Evans, who will be talking about preparing for COVID-19.
Great. Thanks, John, and thanks to FCCM and all of you for the opportunity to be here. I'd also like to take the opportunity in the moment to thank Dr. Peng and all his colleagues in Wuhan and in Hubei province for the incredible work that they've done, as well for sharing all of that information for us so that we can help to prepare as this virus potentially spreads to our communities. So with that, this is not a research presentation. I'm going to take a step back and try and be really practical with some guidance about what steps we might be able to take now. And I think I'll echo a lot of points that Ryan Maves just made in terms of the central nature here of really, really tight adherence to infection prevention and control is the root of how we're going to approach this. I don't have any financial conflicts to disclose. I do get some salary support from the National Ebola and other emerging diseases Education and Training Center, which is funded by HHS, ASPR, and CDC. So these numbers need to be updated after today. This is as of before the weekend, actually, where we had 15 positive cases in the United States, just to put that in perspective of what we're looking at in terms of global numbers, and a total of 443 persons under investigation in the United States. Those numbers have clearly changed now with the repatriation of American citizens, particularly from the cruise ships around Japan. So those numbers will be updated later tonight. I wanted to start with kind of the take-home messages, in fact, which is, I think, the keys to how we're going to prepare here. And that is really a central focus on some of the ideas that Ryan already brought to bear in terms of early identification, prompt isolation of persons under investigation, and then activating systems to inform public health colleagues and our colleagues in infection prevention and control to mitigate the spread to other patients or to healthcare staff within our institutions. I want to talk briefly about the hierarchies of control with a focus a little bit on PPE, but recognizing that PPE is not the central way that we control spread of infection. Tight adherence to infection prevention and controls, how to use PPE, resources that are available to you. So the first thing I want to call your attention to is what's posted online at the CDC, which is a hospital preparedness checklist. And this is more geared towards institutional preparation, but I think us as individuals also can take points from this home in terms of helping our institutions prepare, but also helping our units and ourselves become ready to deal with any emerging pathogen. This is clearly not COVID-19 specific. This applies to any situation. And as Ryan already mentioned as well, you can use many of these for responding to seasonal influenza as well, which clearly has a major impact on us every year. So we need to know what our procedures are for rapidly identifying and isolating persons. We need to make sure that we know where our airborne isolation infection rooms are and if they're functioning, so developing a close relationship with our facilities management folks. We need to understand what we have in terms of PPE availability, supply chain, and begin to develop some contingency plans for what PPE might look like in shortage of supply. We need to think about what our surge capacity procedures might look like for not just a single individual patient with COVID-19, but rather a small cluster of patients, a family, or even a potential surge of a larger number of patients. Where would your overflow areas be? How would you apply environmental infection control in those situations? And review procedures for how we would get specimens to the lab, particularly since the diagnostic testing, as we already learned, is done in the regional public health labs or at the CDC. So these are not testing, confirmatory testing for COVID-19 cannot be done at the hospital level at this time in the US. And then we need to assess the effectiveness of environmental cleaning procedures. Some more highlights from this checklist include ensuring that our healthcare staff has been medically cleared and fit tested and knows how to safely use an N95 respirator. Now is a great time to provide education, refresher training to our staff regarding the diagnostics, some of the clinical information as we're learning how this disease behaves and evolves, how to get specimens, what specimens are necessary for testing, how to appropriately use PPE, and where these patients would go within our hospitals. And then critically around this, we also need to log who's involved in the care of these patients so that we can enroll them in symptom monitoring programs as needed. It's also really important to think at now how you would approach visitors for patients with COVID-19 in your institution. What kind of restrictions might you impose upon visitors in that setting? We saw this, I broke this down. This is sort of that first critical step. If you think about where our vulnerabilities are in the healthcare system, it's predominantly most likely to be before these patients are identified as having COVID-19 or seasonal influenza or any other readily transmissible pathogen. So facilitating processes to make sure that we can identify these patients promptly is clearly our first and probably our best line of defense. And this is directly from the CDC, again, in terms of the schematic that they represent for the COVID-19. I would actually recommend that perhaps we've sort of flipped the script here. And because the CDC algorithm starts with travel first, and we just have to remember back to Ryan's slides about the impact of seasonal influenza and think perhaps what we should be doing at sites of entry is not talking about travel as the first question, but rather fever or symptoms of lower respiratory illness as the first question, and use that as the opportunity to implement risk mitigation at that stage. So anybody with a fever, cough, respiratory symptoms should be given a mask to try to control transmission within our facilities, sort of regardless of diagnosis. That also gives us the time then to safely pursue questions about travel. And these are just some examples from different medical centers and different systems around the US in terms of signage that can help folks to identify patients early. And you can see, at least at the Emory system here, John is probably quite familiar with this, is that it starts with fever and face mask, and then it proceeds to travel. And I think that's a really good way to approach this in general from an infection prevention and control standpoint. So if I identify somebody who has some epidemiologic risk, that doesn't mean they're a person under investigation. It means they have some epidemiologic risk and some symptoms. I'm going to put that person in an isolation environment so that I can take the time then to ask further questions and determine if they may meet the case definition to be a person under investigation. So I need to have that area identified where I'm going to put that person. I'm going to then proceed with my evaluation wearing appropriate PPE, and we'll talk about what that might look like. Following those additional questions, and your individual hospital procedures may vary as to what point you involve your local infection prevention and control team. But following that, if you think a person meets the case definition, you're clearly going to activate notification of your local public health jurisdiction and decide if testing for COVID-19 is indicated. We saw this already. I just want to bring it home that these criteria may change over time. They've already changed in the last few weeks as the outbreak has spread from Wuhan City to Hubei province in a larger sense, and then to other areas within mainland China. So keep your eye on these sites on the CDC because the case definitions of PUI are likely to evolve as if we develop significant community-based transmissions in sites outside of mainland China. Hierarchy of controls, some of you may or may not be familiar with. This is a sort of a NIOSH pyramid for this that describes how we can mitigate risk from it. And many of these don't readily apply to us in the healthcare setting, but they're, I think, a good construct for us to think through how we can help protect patients and ourselves from that. And I'll call your attention that PPE is down at the bottom here. So it's not the first thing we do in terms of mitigating risk. We want to think of, can we eliminate the risk? Can we substitute it? But I think when we're talking about healthcare, we're really talking about these three triangles down at the bottom: engineering controls. So that would be examples of our airborne isolation rooms. Administrative controls, so having safe work practices already in place with people properly trained, knowing who's going to go in the room and making sure that untrained personnel do not enter the room. And then using PPE, of course, as an additional supplement. Where we are with PPE guidance right now is we're seeing a lot of different images come across, certainly media, as to what people are wearing for PPE. CDC PPE guidance is quite clear, and they have some baseline language about that we should be receiving training and demonstrate how to use it, what PPE is necessary, and most pertinently, I think, how to properly don and doff PPE to prevent contaminating ourselves during that process. What the limitations may be are as well. Clearly, PPE that's reused needs to be properly disinfected before reuse, and we should all have policies and procedures in place to ensure that we have safe practices for that. Current CDC guidance is gloves, a standard disposable isolation gown, a fit-tested N95 respirator or equivalent, and eye protection in the form of a face shield or equivalent. That can be goggles, that can be, for example, I just have a standard face shield here. So that is, and when you think back to what Ryan just told us about what is known about the mode of transmission, that this appears to be droplet-based transmission, this is appropriate PPE based on that. So this is current CDC guidance. CDC also offers some guidance on proper donning and doffing, and I would encourage you to review that. I would also encourage you, if you want a video of it, if you're more of a visual learner, NETAC, the National Ebola Training and Education Center, has produced a PPE donning and doffing video here. It's available free on YouTube. So if you search YouTube for NETAC COVID-19 PPE, it'll give you a video for how to don and doff this recommended CDC PPE for COVID-19, as well as I think take you through some of the safe behaviors in PPE. From that, you'll notice everything starts and ends with hand hygiene, which should be our normal practice anyway in the ICU. Aerosol generating procedures, I think, provoke a certain degree of anxiety in people when we think about respiratory transmitted pathogens. And so the guidance is to basically be cautious about this. And if you're doing something like bag valve mask ventilating a patient, intubating them, delivering nebulizers, inducing sputum, I think there's an unanswered question about the use of non-invasive ventilation in this patient population and what that may do in terms of infection control. But there are certain things that you can do to mitigate that. You can put HEPA filters on the expired air limb. You can do that to a bag valve mask ventilator. You can obviously do that on a standard mechanical ventilator. If you're performing procedures like this, they should take place in an airborne isolation room, and you should limit the number of personnel to only those numbers that are absolutely necessary to do that. And obviously the personnel who are doing that should be trained in proper PPE. I want to spend just the last couple minutes sort of drilling down on some of this, because it's not. People focus a lot on PPE talking about equipment, and it's not just about equipment and supplies. It's about how we use them and how we behave in them. So I really want to drill down on this, and we'll kind of go around this clockwise here. So the way we behave in PPE is one of the central elements of how we keep ourselves and our colleagues safe and our other patients safe. So reducing the environmental bioburden. So trying to keep the room environment clean. We don't know exactly how long this virus may persist in the environment. So using things like while we're in the room, taking the opportunity to disinfect and wipe down high-touch surfaces may mitigate the environmental bioburden. Trying to keep our PPE relatively clean. If I'm doffing cleaner PPE, I'm less likely to contaminate myself during the doffing process than if I'm doffing PPE that's grossly soiled. Obviously, don't touch your skin, your hair, your eyewear. We see a lot of reach up under the face mask to adjust your N95. That's a big no-no. Again, use additional barriers when you're going into an area that you think may be highly contaminated or doing something that you think may result in gross contamination of your PPE. Know what your breach protocols may be. Don't hesitate to clean and disinfect or change your gloves. You can use alcohol-based hand rub on exam gloves to disinfect them. You can do that. You can also change them during that. Be aware of your condition. Don't get yourself into trouble. So if you're having trouble with an N95, feeling hot, feeling excessively sweaty, that's the time to call for help and get out of that room so that you don't have to be extricated from that. If you're using a trained observer, which is not required by CDC in this situation, if you opt to use a trained observer, and follow the instructions from your trained observer. And then obviously check your PPE for contamination before doffing. So to summarize again, the situation's rapidly evolving. There's, I think, very substantial uncertainty about what the impact may look like in terms of, we think that Ryan gave us some great information about current data about case fatality ratios, but I think we also know that if we're in the United States, if we experience a significant influx of seriously ill patients, that will put stress and strain on our healthcare delivery system. None of us have tons of extra capacity in our emergency departments, inpatient units, or ICUs, and I think we need to be prepared for that. We need to know what our process is for identify, isolate, and inform, and we need to be testing that now. Now is also the time to review and train on the proper use of PPE. This is the window of opportunity to do that. It's a good idea to do in general, and this is a great opportunity to do that. We talked a little bit already about preparing to make sure that we have the capacity to collect clinical data. And I think that's one of the things that Dr. Peng illustrated to us really nicely, is that his ability to collect and report clinical data has informed us. And so we need to be able to do that as well. And Ryan gave us some resources to do that in terms of there are already pre-prepared case report forms. You can submit and get those through your IRB now, so that if you start getting patients with COVID-19, you can start pulling data on those patients. And again, the keys to preparedness across any event is always communication, collaboration, and coordination. And I will stop there by just putting some resources up there. This CDC website, of course, the WHO website. This Johns Hopkins Center for Health Security is publishing a fantastic daily newspaper. We have some neat resources on the NETEC repository, and then WHO just released an update to their severe acute respiratory infection course, which is a fairly lengthy online course. It has about 12 modules, takes about 10 hours to complete. It's more geared towards low and middle income countries, but I think still a great resource for us, and I'll stop there.
So while it's at 5:15, we do have this room for a little bit longer, and we have both Dr. Maves and Dr. Evans to answer questions. Unfortunately, we had a technological kerfluffle with Dr. Peng, and he will not be available for answering questions.
This is for Dr. Maves, Tim Buckman. You mentioned that there is a significant, or at least 10% estimate of superinfection with this viral pneumonia. Is that a low estimate, a high estimate? And the reason I ask is that in the data that Dr. Peng showed, it appeared that there, among the survivors, there was actually a significant rise in the total white blood count. That is, there was a significant neutrophil leukocytosis. Would you comment?
So actually in Dr. Peng's series, it was less than 10%. He isolated a handful of cases of Acinetobacter and some likely commensal yeast. So his experience is less than that. The 10% comes from some other series, and those are among hospitalized patients, not from the full 77,000 or 72,000, I'm sorry, number of cases. So whether a post-viral bacterial pneumonia is a major part of the immunopathogenesis of this, I think is completely unknown, and that 10% is entirely speculative off of a few small series. Again, Dr. Peng's experience doesn't reflect that, and I think it is premature to say at this point. But it's a great question, and that's one of the, like flu and metapneumovirus would be two major comparably severe viruses that would have a similar syndrome. Wow, easy crowd.
Thanks very much. Very timely and informative. Any information about the effect in children?
I think we don't know. Certainly the number of cases reported in children appears to be low. We have to remember that the case definition that was publicly reported has changed in recent days, and previously it was a laboratory confirmed diagnosis. And so you wonder about underreporting of milder disease. So if the clinical disease is milder in children than in adults, they may not have been tested. I think we'll have to keep an eye on that now that there's also a clinical definition for case reporting, particularly from Hubei province, to see how that changes. But I think we don't know. There does appear to be a different signal in children rather than adults. Do you want anything?
Oh, no, that was great.
Jeff Bellingham, two questions. First one is if you could comment on the story where some patients test negative potentially over a number of times and then positive. And the second one is the choice of 14 days and some of the stories suggesting that might be out to 20 or 24 days before you can move from being asymptomatic to symptomatic.
In regards to the negative testing, there was, this was reported in the media in my home city in San Diego, cases of initially negative PUIs who were later found to be positive. That appeared to be the result of an administrative issue rather than a technical issue. Certainly goes to reinforce the importance of administrative controls in addition to technical controls. But any test has sensitivity and specificity, even anything as remarkably sensitive as PCR. In terms of the 14 days, it seems that the median time between exposure and clinical symptoms is about 5 to 6 days. So the 14 days is actually at the longer end. I think there will certainly be handfuls of patients who shed for more prolonged periods of time or have a longer period. Like anything, it's a bell-shaped curve, and there's going to be a tail at the other end. But I think with the 14-day period, that's keeping us within a few confidence intervals of the great majority of cases, at least as described thus far.
When I read, like in the news about the cardiovascular complication, that there is a specific predilection of the virus to coronary arteries. So what are the clinical implications? Do we expect like STEMIs, cardiac ischemia, and what are the treatment implications?
So I don't think we have an honest answer for you about that, sir. I will say that influenza is also clearly associated with myocardial infarction and myocarditis as well. It's called hemagglutinin for a reason. It's a prothrombotic state. Whether that is also true of this coronavirus, I think, is unknown.
I think I heard you say that there's about 80% genetic identity with the previous SARS or SARS type 1.
Correct, sir.
For which there was a vaccine developed, I understand, but was never used.
Right.
Is there any thought that that old vaccine would be potentially effective against this new virus?
So kind of a two-part answer. So sort of a two-part answer. So number one is I am certain folks are thinking about that. I'm not directly involved in that, and I can't speculate. I can say, and this is in the press, that Dr. Fauci at NIAID anticipates having phase 1 human trials of an investigational vaccine, likely using, and I'll ask Dr. Evans to correct me if I'm wrong, the RNA virus, the RNA vaccine platform that they've developed and tested for Zika and some arboviruses previously. So that should be, hopefully, in the next few months. In terms of cross-immunity, there is some interesting literature on the effects of cross-immunity between different coronaviruses. There doesn't appear to be cross-immunity between, say, like the other 4 routine human coronaviruses, right? So I don't think we would necessarily anticipate that in this case. And there is this interesting signal from animal coronaviruses that secondary infections may actually be more severe, kind of analogous to dengue. So I would be hesitant to assume that an existing SARS vaccine would be useful in this case, although it certainly does provide a model that vaccine development could use going forward for developing a specific vaccine.
So please join me in thanking Dr. Maves and Dr. Evans for their timely presentation.
And Dr. Peng. And you.
And we'd like to thank Dr. Peng in absentia for his wonderful summary, and thank all of you for sticking around well past the 2-hour mark. Have a fine afternoon.